Yeah. At this moment, nobody's here, but well, except me. Yeah, today's Monday. Yeah. Let's wait. That's all. Oh, Fabiola is here. Hi, Fabi.
Hi.
Hi, how are you?
I'm fine, and you?
Fine too. Everything's okay at this moment. Yeah. So patience.
Good.
Yeah, that's all. Yeah. I'm looking for the the presentation. Yes. Today is not a long session, I think. Hi, Johan. Hi, Ruth. Today we don't have too much material to talk about, so it's not just an hour. I think we're going to stay. Yes. Yeah. Okay. We are for. Tell me, people, the moment you want to start or you want to wait a little bit more, that's okay for me. Okay, you tell me the moment you want to start. That's okay for me. Okay, let's go ahead, okay? We wait 5 minutes, it's enough time. Well, today it's not a very long presentation, class that considering the point of view, it's a topic we must do. That's why we are going to work with this. Okay, so let's go. Today we are going to talk about the screening and immunization, epidemiology, general and fast view, and medical ethics, few situations to share, to talk about, and then consider taking in account, especially the vocabulary, okay, the vocabulary. So let's go ahead. Talking about the screening and immunization, well, all of us have the experience taking or receiving some vaccines, especially in these pandemic times. That's the reason we are taking online sessions for almost all the university classes, school classes, and everything that implies studies and people meetings. So that's why we have to consider that talking about the screening specifically, well, it's a way of identifying people at increased or greater risk for a condition, although they do not yet have any signs or symptoms. In some cases, mass screening, the screening of large numbers of people, is appropriate. For example, in the past for tuberculosis. We know the history about tuberculosis, so we got the idea that when this condition has been discovered, the way of getting the diagnosis was by screening tests. Okay, the tuberculina test was a way of getting the idea that we were in contact and we have the bacillus inside. So that's the way that we are getting the correct meaning, okay? In other cases, only those with high risk factors like family history of conditions such as cancer and diabetes are screened. We know when we have a patient with a specific health situation, we ask for details, lots of details during the anamnesis, right? And taking that situation in count, think that we have to get all the information about the family history of conditions, of illnesses, or diseases, or I don't know, that kind of problems. We get a screening during the medical act, taking the information to the medical history. So we consider that when we do medicine, when we practice medicine, we are always making screening information, identifying the risks, greater or increased risks. We have to consider this, okay? There are always false negatives, cases where a patient has a disease but the screening does not identify it. It usually happens. And there are also false positives, where someone is told they have a disease when in fact they do not have. We have to consider the false positive as not as such a big problem. We must be worried about the false negative, because losing the positive data, we can miss an important date, an important number for treating our patient, and of course, identifying the correct treatment. Furthermore, with some diseases, early identification is not benefit to the patient as there are no treatment available. So to get the screening in a correct way, even if it's false or positive, it's a false or positive or negative result, I mean, there's no mark any difference between the treatment and the diagnosis. The screening just gives us idea that there is a situation, and that situation is going to direct us with the patient to get the correct diagnosis and then get the correct treatment, make everything okay. As we were talking in the last class, I mean, always do your best, okay? So that's the idea we are getting about it. Common screening tests, of course, we know lots of them. They can be made during the pregnancy time as the neural tube defects and Down syndrome risk. We know about it, the AFP alpha-fetal protein in pregnant women, and we make it in the between. Then we get the idea that newborn could have that problems, or maybe we discard this. Okay, it's easy. The breast cancer, usually in our country, we have first the ultrasonogram, okay? The cervical cancer with the smear test. Every year we have to do this test. All women between 20 and 60 years. It says every 3 years, but in our societies, every year until we find five negative results, then we can take it every 5 years. The cardiovascular disease, the blood cholesterol, for example, within high risk factors when we are more than 40 years, okay? And we have to make it every year. And if we are in risk, obviously taking the control could be every 6 months, 3 months, depending on the case and the treatment we are taking about. About the secondary prevention, for example, we got in the cardiovascular disease a positive result, and the cholesterol is upper than the 4th percentile. We consider that we had the blood cholesterol as a test. And we have patients with the heart disease as a subject, not every people, not all the population. And now we have the control every 6 months, as I was telling you, but depends on the situation. It could be every 3 months too. The diabetic retinopathy, of course, we make the ophthalmoscopy, the fundoscopy. Of course, the patients with diabetes are our subjects, and we make it every year. At least it's every year, but if we have any reason to make it every 6 months because it is a very fast progressive situation, we have to make it. Most of these criteria can change. Then we have this list taking in account more screening tests that are important to consider and that we usually do in our healthcare system. For example, we make the TSH in the newborn for detecting hypo and hyperthyroidism. And that's important because in many countries we don't take it and we just live with the consequences of these situations. Or maybe in our country, we also do the PSA test for prostate cancer in men that are over 50 years. You consider it. Sometimes we have campaigns taking in account the fecal occult blood for colon cancer. It's not a common situation. No, we don't see at least, I don't know, in consult around 5 or 3 patients every day. It's not a daily situation we can consider. That's why in campaigns we can consider to take this test, taking in account the medical criteria for this situation. The same occurs with the ocular pressure of glaucoma. The glaucoma is a very common situation in elderly people, and it could be asymptomatic until the point we decide to ask for the ocular pressure, or maybe if we have the experience, we can develop this evaluation. It's not as hard as we think. Just we need to practice to get in touch with the devices, with the equipment, and then do it. And having the possibility of getting this, we send it to the ophthalmoscopist to get the correct diagnosis. Okay. Talking about immunization, well, of course, we have national programs. Every country has its own program according to their epidemiological situation, the diseases, sickness that are the most common ones in every country. But we have to consider that this point of view is a very, very huge idea to develop. So it's not a point at this course to review the national immunization program. That's why we are considering just immunization for travelers, because it's not a point that we usually study at the university. If we study it, is because we are traveling, not because we are considering for people that is coming, or maybe our migrants or immigrants from our country. So immunization for travelers, very big idea, is the travel vaccines that are specific immunizations given to travelers prior to going to certain areas to protect them for acquiring serious life-threatening diseases. Okay, if you are going to Kenya, you have their specific protocol for immunization for travelers. There is not the same for every country. Okay, and when you are considered, what does fully vaccinated travel mean? When you as a traveler are considered you are fully vaccinated. If you have received both doses of an accepted to those vaccine series, regardless of how long it has been between doses, you are considered fully vaccinated, okay? So that's just the idea for getting that we must have all vaccines a country is asking for in order to help them to control their epidemiological situation. That's the way. And of course, we have some carnets on immunization, international programs with malaria, for example. And of course, in every continent, most of the countries have their own vaccine programs, as I was telling you. For example, to North America, just the anti-influenza virus vaccine was the most important in the moment this picture was published. But now at this moment, the anti-COVID, of course, is one of the most important, but not any vaccine, not all of them. They are supposed to be specific vaccines, okay? And we all know which one we are using, we received, and now we can consider which our vaccines for going to another country. For, I don't know, if any situation, we must have the vaccines, the most important ones, which ones are the most important. For going to Cuba, for example, where the malaria vaccine, hepatitis B, the anti-influenza virus vaccine, and that moment was not easy to get it, anti-yellow fever vaccine, of course, and the program, the national program vaccines must be complete. If you didn't have all of them, you couldn't go to Cuba, you couldn't enter to that country. And it's just an island, so consider how is the situation in other countries. For Europe, the anti-influenza vaccine virus vaccine in that moment was the most important, but now the anti-COVID, considering every kind of vaccine, okay? And then we have this reading when we have, of course, blackened expressions or blackened words showing us the vocabulary we must practice for this kind of situations, okay? Maria Fernanda, are you there?
Yes, teacher.
Hi, Maria, nice to hear you. Can you read, please, this picture?
Sure. Hepatitis A, or immune globulin. Transmission of hepatitis A virus can occur through direct person-to-person contact, through exposure to contaminated water, ice, or shellfish harvested in contaminated water, or from uncooked fruits, vegetables, or other foods. Hepatitis B, especially if you might be exposed to blood or body fluids. For example, healthcare workers have sexual contact with the local population or be exposed through medical treatment. Japanese encephalitis, if you plan to visit rural farming areas and under special circumstances, such as a known outbreak of Japanese encephalitis. As needed, booster doses for tetanus, diphtheria, and measles, and
Yes.
a one-time dose of polio for adults. Malaria, your risk of malaria may be high in these countries, including cities. Travelers should take an effective anti-malarial drug. Rabies, if you might have extensive unprotected outdoor exposure in rural areas. Typhoid fever can be contracted through contaminated drinking water or food. Large outbreaks are most often related to fecal contamination of water supplies or foods sold by street vendors. Vaccination is particularly important because of the presence of STF strains resistant to multiple antibiotics in this region.
Thank you so much, Maria. So now you can get expressions and vocabulary that's important for us to remember and to practice, okay? In that way, we have to try to use these expressions when we explain the importance of vaccines, no matter if they are for travelers, for our people in our country, for someone who is anti-vaccine, anti-vaccine minded. That is a very funny situation when you talk with them, because sometimes when you talk about history in medicine, they don't have a way to avoid our ideas about considering this perfect way of prevention. That's why we are talking this point. We are taking the idea, the general idea about the vaccination, okay? About epidemiology, well, we have to consider that it's a very, very big branch in medicine and has lots and lots of topics, lots of ways of working. It's not just taking numbers and preparing images, preparing data. That's not the objective of epidemiology. It's a complete, huge study of the distribution and determinants of health-related states or events in specified populations, and the application of this study to control of health problems. So when a doctor becomes an epidemiologist, gets the responsibility of making the research, making the process, trying to understand how an infection could be spread and how we can control it and prevent it and avoid that difficult situations. That's the way we must consider work. That's the way a correct epidemiologist do their job, because it's not an easy way. They control, as we can see in the picture, they evaluate the sterilization, the equipment, of course, the epidemiology in a specific situation, of course. They evaluate health, they evaluate lots of the situation for being precaution in prevention, the hygiene, the outbreak. A very common phrase at this moment, at this historical moment of pandemic times, is that we are in the 2020 and we are still teaching people how they must wash their hands. So something we are losing about information during this period of time in our social history, in our social behavior, in our social education. It's not possible to still be teaching how to wash hands, how to get away from risk, from, I don't know, from garbage, for example, how to treat garbage in order to try to separate and to work and to recover, to practice that kind of stuff, I mean. So it's not an easy fact doing it. It's not an easy fact to be a correct epidemiologist. In so many countries, we just consider an epidemiologist to the one that is, for example, the health department expects from the public and healthcare providers, clinicians, laboratory, and hospitals some specific information about diseases, about many situations that are related just for sickness, for diseases, for illness, right? And with that numbers, they make their informs, the charts, their I don't know, their graphics, everything that can show how the society is getting worse or maybe recovering. They make the report, the public health care, make the report to the health department. The health department asks again for new topics about the same situations. It's not only the objectives we are looking for. When we talk about epidemiology, we have to consider when we make an infection control, the most important professional could be said, I don't know, in a very general definition, is the epidemiologist, because he has the correct strategy for considering the area for studying, for trying to get the correct equipment, for protecting that people that's going to collect the information and that kind of situations. So we must consider that this epidemiology is not this cycle of situations. It's a very easy chart showing us the big idea of being an epidemiologist, but the correct job, it's maybe supporting all the research we make, because we collect the data, we organize it, and we of course prepare it considering the rates, okay? The rates are important for us because comparing rates, we can have the numbers that show us in an objective way, as an objective point, how we are working as a society in order to protect or recover or to control a situation. The speed or frequency with which an event or circumstance occurs per unit of time, population, or other standard of comparison. That's a rate. That's why we have to try to understand the idea that if we have this chart, it's a very easy chart. It's in order to get information for making the rates. This picture is showing us an example for comparison situation in a period of time, okay? And how at this moment is working on taking this example just. Now we talk about frequency using the combinations with rate. For example, birth rate is the number of births in a population group of people. We know it, we checked it during the medical school. The death or mortality rate is the number of deaths in a population. How many population dead in a year? We know it. The case fatality rate, the number of deaths from a particular disease, from COVID, for example. We know about it. The survival rate, the number of patients still alive after treatment for a particular disease, lung cancer, for example. So we must consider that getting this idea, we have these ways of expressions. That's why our friend is in the middle. The birth rate in Singapore, for example, is 1.2 per 1,000 population. I got 10.2, I'm sorry. So the birth rate, don't forget this expression. Another one, the infant mortality rate in Singapore is 3 per 1,000 live births. Okay. So taking these expressions, we get the correct information and we show the data we are trying to express in an easy way for getting understood, okay? Other words used to talk about frequency, common, uncommon, and rare, okay? Malaria is common in many developing countries. Okay. Malaria is uncommon in developed countries. Malaria is rare in developed countries. Malaria is a very common situation in tropical countries, in tropical places. So we consider this way common, uncommon, and rare in, and then we continue with our expression, okay? Tuberculosis is common in our country. It's very common here in La Paz, for example. Another example, rabies is rare in developed cities, for example. Rabies is rare in vaccinated dogs population. If they are vaccinated every year, as we expect during the vaccination program of rabies, we didn't have the situation of having a dog with that infection, right? Now I have two pictures showing us an example of rates, showing us the percentage of these causes of fetus ovitus. And I have a picture showing us the historic example of death rates, considering many situations. The percentage, the rate, the years, and the situation that is with the key of understanding, okay? How the HIV infection is going up and up and up through the time. It's an old picture, but it's a good example for understanding the idea. Talking about incidence and prevalence, I know those ones are concepts that sometimes we don't want to practice, but it's important to get the idea and then continue with this. Well, we have prevalence, the number of people in a population who have the disease at a particular time. Here we have the formula for working with it. Prevalence, all cases, AL, yeah, just a key for memorizing. All cases over population in risk. I'm sorry. You see, LA. Incidence, the number of new cases of the disease during a particular time. Incidence, the N again, new cases, number population and risk in a particular time. So we must get this as a refreshing idea because it's just for remembering, okay? So taking these examples, we consider the way of expression. Again, we have our friendly guy showing us the importance of this slide. The incidence of malaria is high in many developing countries. The incidence of malaria is low in developed countries. In Cuba, the incidence of malaria is low, even it's a developing country, okay? Maybe Cuba is one of the poorest places I've been living, but in the healthcare program is well structured, is well planned, well planified, so they can control and prevent and work in many ways to avoid situations that could be common in developing countries. That's why the incidence of malaria is low. And for example, going from our country to Cuba, you have to be in quarantine for around 7 days without contact and taking the drugs for avoiding the probability of getting infectious, no matter if you don't live in a place where malaria is a problem, or when there is there are cases of malaria at that moment. Just because you are from Bolivia, you have to take the drugs, the chloroquine. Well, the quinaquine, I don't remember all of them, and they are horrible, of course. I don't recommend any to take them. So we have another way of expressions in the bubbles. the incidence of HIV infection is highest in sub-Saharan Africa, for example. The incidence of HIV infection is lowest in the Caribbean. Okay. Note, you don't say the incidence of malaria is common. Of course, it's not a correct expression. The incidence is low or is high. Common, it's not considered as a correct way of explanation the situation, okay? The incidences of diseases in different groups are often compared, just making comparisons with these bubbles again. Rheumatoid arthritis is more common in females than in males, for example. Rheumatoid arthritis is less common in males than in females. You can see the opposite situation. Men and women are equally affected by restless leg syndrome. You remember that way of comparison, so it's easy to make, right? In that way, we are going to be practicing this week this way of expressions because they are important for us to take in count, okay? So we have to consider more vocabulary, the association and causation. Well, studying the incidence of a disease in a particular groups of people can lead to the discovery of causation. What makes it occur? For example, the high incidence of lung cancer among cigarette smokers suggests that the smoking is a causative factor in the development of lung cancer. We all know this. The causative factor of lung cancer, one of them, of course, is smoking. We don't have any way of avoiding the idea. Another causative factor, maybe, I don't know, Agar, can you give us an example about a causative factor about any situation you would like to share? Agar. Well, she's not there. Any volunteer for giving an example for a causative factor? It's easy.
Can I read?
Ariana?
Yes. Association and causation. Studying the incidence of disease in particular groups of people can lead to the discovery of causation, what makes it occur. For example, the high incidence of lung cancer among cigarette smokers suggests that smoking is a causative factor in the development of lung cancer.
Thank you, Ariana. Can you give me an example of a causative factor different from a lung cancer?
Alcohol and cirrhosis.
The cirrhosis, perfect. So it's easy to make, right? You know the causative factor, so you have the idea about the disease you are talking about. That's not something, I don't know, not easy to make. We all have the idea. We are making the medical school these situations. The ones that are in 4 and 5 year of the university, of the med school, they are taking this class at this moment, I think. That's the way of understanding. Thank you, Ariana. So, Fabiola, are you there?
Yes.
Yes, can you read this slide, please?
Okay. However, care must be taken not to assume every association between a disease and measured variable is causative. To say there is an association between two things simply means that they occur together in a certain situation. For example, several studies have indicated high rates of lung cancer in cooks, although this could be a consequence of their work, perhaps caused by carcinogens in fumes from frying. It might be simply because professional cooks smoke more than the average. In other words, smoking might confound the association with cooking.
Okay, thank you so much. So you can see the difference, okay? The risk factor, the compound causes, and the situation that could be in a confusion. That's why epidemiology is important. We have to check the differences between situations and then get the correct causative factors, avoiding that kind of situation, the confound associations. So cooking with wood, maybe using wood by cooking, for example, not just cooking. Cookers, of course, have another kind of risks, any different way of laboral risks to consider, but not lung cancer is one of the most important in that kind of population. So until this moment, any question that anybody could have? Something that is not clear at this moment? Well, okay. Belkin?
No, everything is clear.
Okay, thank you so much. So considering that we have, again, blackened words, that's the vocabulary I've been asking for homework and evaluations at the end of this module 2, okay? So practice, read again, and if there's any question, I don't know, when you are checking or studying, let me know, there is no problem, okay? So we are going to correct it. So we have this chart. That is a way for understanding these concepts that sometimes get in mind, and it's not easy to associate with our real work. We have the risk factor, the component causes, the biological effect, and the health outcome. The risk factor, the law says, the social determinant. We all know what is a social determinant. The component causes, the tobacco smoke pollution in a specific population, of course. The biological effect, mutations in respiratory cells, and of course, there had to be a genetical predisposition for this one. And the health outcome, the lung cancer. We have to consider the complete situation, not just a step free of the rest, because it's not the correct interpretation. Now we have a very huge problem at this moment, the medical ethics. Because all of us might be considering that when we talk about medical ethics, it's how we as a person work. How do I do think, how I've been prepared from my parents, from my family to act in the society, and how as a doctor, the rest of the people expect I should act, okay? Of course, we are trained for taking decisions. All the medical school, we are practicing how to take a medical decision, how to express the diagnosis, how to give a good no about a treatment, a condition, I don't know. But that medical ethics get us in that kind of situation that could make us consider what I am doing at this moment, why I decided to be here. And that's a question, because sometimes you don't have a clear idea what medical ethics are taking, what's the correct way of thinking on this situation in order to respond in the correct way. That's why, well, Johan, can you read this slide, please? Are you there?
Yeah, I'm here, of course.
Yes,
Medical ethics. Medical ethics is concerned with the obligation of the doctors and the hospital to the patient along with other health professionals and society. The health profession has a set of ethics applicable to different groups of health professionals and healthcare institutions.
Thank you so much, Johan. So you can see, it concerns not just the doctor, all the society that is considering this situation, and the health professionals in general that are taking in contact with patients. Okay, so sometimes we don't have to think impersonal, we have to think as an institution. And it's not easy to take that position, I tell you by experience, because you see, as a person, I know that I'm making a mistake, but as an institution, I know that I'm doing my best. So which one I should choose? Continue doing my best or acting as a person, an individual? What would you do? It's not easy to answer. It's not a piece of cake. That's why for understanding the medical ethics, we have 4 pillars, 4 ways that we must always defend and practice, and consider that without these 4 pillars, we are making all the time mistakes, okay? And they are so important for us because we need to get in touch the idea and then get used to these ways of thinking, because we are doctors. We are not of course not getting in controversy with other professionals. We are not any other professional. We are different. We decided to take a different way of life. We decided to take a lifestyle that led us to be a defender of many situations. For example, violence situations, rape situations, I don't know. Sometimes patients ask for us for lying, for not getting discovered to their family. It could happen. It happened to me twice. And of course, we cannot do this, okay? We have to consider that becoming a doctor gives us a huge responsibility, and that responsibility is supported with these 4 pillars, okay? The pillar of beneficence, the pillar of non-maleficence, the pillar of autonomy, the pillar of justice. Well, we have during the history of medicine, lots and lots and lots of examples about these pillars, about these 4 situations that can give us an idea that what we are talking about and how we must act about this. Catherine, are you there? Can you listen to me?
Yes, teacher.
Thank you. Can you read, please, the black words, please? Not the chart, just the words. The chart is for reading at home.
Okay, teacher. The pillar of beneficence. The pillar of beneficence is about promotion the good of others in medicine, means acting in a way that helps your patients. The most obviously example of this in providing up to date evidence-based treatment to your patient with the aim of reducing their symptoms or treating their illness.
Thank you so much. So the pillar of beneficence, of course, is looking for the best way for our patient, the best treatment, the best medication, the best in all of the situations. That's why it's talking this important detail, up-to-date evidence-based treatments. If we are not up to date, if we don't have evidence about the correct way of working with antibiotics, for example, we are wasting our time as a doctors, and we are not making the correct beneficence to our patients. The best example for talking about the pillar of beneficence is during the history, of course, is the Tuskegee syphilis trial. This is an example when we have in the 70s an ethical way of treatment, an ethical way of researching the penicillin for trying syphilis, of course, in a Black population in the United States. While they were learning how this medication was working against the syphilis, I'm sorry, the syphilis, they chosen a town with poor people, specifically poor people. Nobody had the idea about reading or writing, and all of them were out sexual education. So they don't have any idea about protection on sexual diseases. They just were in intercourse without taking control. That was the way of poor people were living in that decade. So they were easily contagious with syphilis. Then an unethical colleague, if he could be called colleague, went to that place and decided to practice and decided to offer the treatment to the people by free, without cost. And he was practicing shotting the vaccine, the medication, to a group of control and water to another group of control, of course, and they taking the differences and then studying the steps of syphilis, the phases of syphilis, the primary, secondary, tertiary syphilis, okay? So that's why we got the correct process, the time process, the medical research of the syphilis as an infection, considering the danger and the damage that was being done to that people without beneficence to the ones who received, of course, water. And they, of course, get to the tertiary syphilis, and they were dying. And when people get in touch, get the idea that something was wrong, and not all the ones that were supposed receiving the medication were getting worse and dying, and get the idea that something was wrong, and get the point that was a lie, that doctor was not making the correct job. Of course, they killed him. They decided to take out the doctor. The doctor was a white one. And they said, you are not an ethic one. You are playing with our lives. Black one's mother. So goodbye. They killed him, and they avoid all the experiments. But we have the information because of these kind of situations. So we have to consider this. Sometimes we forget our pillars of thinking, of living, in order to get research, and we have to decide which way of the balance we want to stay. Now we have the pillar of non-maleficence. We have to take it as a big idea. Ruth, can you listen to me?
Yes,
Yes, can you read these slides, please?
yes, the pillar of non-maleficence. Non-maleficence refers to not causing harm to your patient. His principle spans a range of applications, such as a doctor maintaining medical competence and not giving patients treatment where the risks outweigh the benefits. It seems obvious that doctors will not want to harm their patients. Yet there are countless examples of when this principle has been disregarded.
Thank you so much, Ruth. So with non-maleficence, well, it's a clear idea that we got in mind. But what would happen if we made that mistake? What would happen if of course, I didn't consider all the antecedents and then made a mistake with a medication? It's not considered as a mistake in our career. It's considered as a maleficence. It's considered as a huge problem because you are supposed to be prepared for not making that kind of mixed ideas. We have to consider, as it says, the benefits and the risks, and then with that evaluation, we take our decisions. And with that way of taking decisions, we can complete our job, and then do our best as we are telling all the situations, right? We have to consider the non-maleficence, the primum non nocere is the most important idea we have in mind when we decide to work with people, specifically vulnerable people. Every patient comes to us vulnerable. Nobody comes because they feel happy and they say, okay, I'm sick. Okay, everybody, let's clap with me. I'm sick and I'm dying. No, of course not. Take this idea. If you are sick, you look for someone that can help you. And of course, that one that is going to help you, it's not your friend, it's not your relative, it's nobody for you. It's a completely strange. And that patient trusts on us without knowing who we are, even our names, and they give us their life for solving a problem that they cannot do by themselves. So that's important to get the idea. That's why non-maleficence is important for us, for our way of thinking, of living. And we have another great example about it. Okay, Harold Shipman, and infamous GP in England. He, during his job, he was usually killing people, killing patients. He has 15 patients proved, but now at this moment, there could be more. So we have to consider that we have to take it in count. We have 15 that are improved. He used to use high doses of painkillers in clinical indications, changing indications, and he killed the patients. That's why we don't considering, we are considering him as a no colleague, of course. He broke all this principle of this pillar, and he said, okay, I'm going to use the medication for killing people, and that's all. And fresh situation like this was discovered in the USA. Was an oncologist who was very famous, very famous. I don't remember the city specifically, but he was used to diagnose breast cancer. In an opportunity, a nurse get the annual control. She decided to go to this doctor because he was very famous, and he made her an ultrasonography, and just with the picture, he said that was cancer, then they must start the chemotherapy as soon as possible. Of course, this nurse was so smart and didn't say that she was a healthcare professional. She said, okay, let me get the idea, let's make all the situations, let me understand the situation, and of course, give me time for solving this. She was scared. She decided to go to a colleague, and that friend, the friend of the nurse, told her to look for a secondary opinion. They went to another doctor. This new doctor made all the lab tests, more studies, and he said that she was not with cancer. She was not sick. There was no any situation. Everything was okay, was normal. And she said, but that famous doctor told me that I have cancer. What should I do? So the friend, not the patient, the friend decided to make it as a big problem and started a demand. Okay, she demanded the doctor, the oncologist, and said that he was giving false information about health situations. Authorities started studying this case, taking more medical histories, more medical reports, talking with their patients, and taking labs in other places that were not in contact with this doctor, with this oncologist. And they get as a conclusion that this doctor was not given the correct diagnosis and was using and applying the chemotherapy for same patients, not cancer patients. And as a consequence, they, at that moment that the judge was in progress, they could prove around 120 women dead. So you see, and the judge is in progress. So we have the pillar of justice. Belkin, can you read, please? Belkin. Oops, well. Well, the pillar of justice talks to us or refers to us to fairness within medicine, an equal distribution of resources. I'm sorry.
I can continue.
Hi. I'm sorry. It has been considered in terms of equality and equity of healthcare across patients. We all know what justice means. We all know what it is. And we all have to consider that without justice, we cannot work. I'm sorry. We have this picture that shows us the difference between equality to equity and justice. I don't know, any volunteer for reading this, please?
Yeah.
Oops, Ariana, maybe it was the last name I read.
Okay, equality. The assumption is that everyone benefits from the same supports, this equal treatment. Equity. Everyone gets the support they need. This is the concept of affirmative action, thus producing equity. Justice. All three can see the game without supports or accommodations because the cause of inequity was addressed. The systemic barrier has been removed.
Okay, thank you. So taking these definitions, we have the idea about equality, equity, and justice could happen, how it works and how we can lead these situations, how we can treat with this, how we can work on this, and then make the correct division of the resources we have, and that we can reach and divide and send to our patients, to our people. Sometimes it depends on us to look equality and equity and justice, but it's not easy to get the correct point of equilibrium, could be said, and then make our correct way of working, okay? So let's consider these definitions for understanding the idea of just. And the most difficult pillar to accept the autonomy of self-determination. John Harold, are you there? Can you listen to me?
Yes, teacher.
Yes, can you read this slide, please?
Yes. The final pillar is autonomy and refers to a patient's right to make their own healthcare decisions. This is also known as self-determination. It means that patients can decide their own healthcare priorities, and it includes the right to refuse treatment. Doctors should inform and advise patients according to medical evidence. However, the final decision should always lie with the patient, even if it goes against medical advice.
Thank you so much. So it's very hard for us to accept the autonomy of the patient because sometimes they refuse treatment without having any idea what we are talking about and the necessity of doing this specifically, right? One of the best examples about this is the Jehovah's Witness, right? When they avoid any kind or they refuse a blood transfusion, considering the religious grounds, they think that their soul is in blood. And if you receive a blood transfusion, you're receiving the soul of somebody else. Well, we know that it's not the situation. We all have the idea what is happening with that specific medical procedure, why we need it. Of course, it's not a free idea, but we know that the Jehovah's Witnesses are not going to understand because their religious idea goes in that way, and we have to respect it. When we break the autonomy of the patient, the self-determination or the autonomy of the patient is when we get the situation when life matters more than that kind of ideology, of idea. For example, if we find a situation, for example, if we receive in our emergency room a patient from a crash accident, a terrible accident, and it's unconscious, and the patient needs a transfusion so fast, we are not going to wait for his family or someone going to get the green light for doing the procedure. We're going to make it. No matter what happens, our priority is to save this life. In order to save this life, we are going to use the blood transfusion, and that's all. But if the patient is a Jehovah's Witness, what we do? We are dead, yeah. Or with kids, it usually happens with kids, and I don't remember in which serial, if it was Grey's Anatomy or Dr. House, I don't remember which one. They had that problem when a kid went alone to the hospital with a brain tumor. He was asking for help, and his parents, when they found him, they said that they were without treatment because they just expected that God make the miracle and save the life of the kid. And doctors take the final decision because the kid was going again without his parents. Well, they just avoided the situation of the parents because it was a big risk for the kid, and the kid wanted to live. And they know that that boy was not in the possibility of recovering with a miracle. It doesn't happen. Okay, so just an example. And for considering that kind of ethics situations, we have to get this vocabulary in this picture. We have guidelines for understanding. There are just a few. We have lots of guidelines. I'm going to try to get all of them for sending you as extra material for reading. Give me this night, please, for downloading, please. And following these guidelines, we have to consider this. The duties of a doctor registered with General Medical Council includes to make the care of your patient your first concern, care, protecting and looking after someone we know. Treat every patient politely and considerately. Give patients information in a way they can understand. Sometimes it's not easy to get, but we must get away. Keep your professional knowledge and skills up to date, as we were saying, in the beneficence pillar. Recognize the limit of your professional competence, very important. Professional competence, level of specialized knowledge and skills. Sometimes we have the knowledge, the skills, but we don't have the title, so we are not considered professional competence. Be honest and trustworthy. Respect and confidential information, confidential, private, secret. We know that we don't have to share our patient information. It's important. Make sure that your personal beliefs do not prejudice your patient's care. You don't have a negative influence on. It's not easy to make, but with practice we get it. Lots of practice, I tell you by experience. Act quickly to protect patients from risk if you have a good reason to believe that, from possibility of something bad happening. I believe that you or your colleague may not be fit to practice in a suitable condition to work. So we have to be alert to all of the situations that are surrounding us. And we have to consider these guidelines. As I was telling you, there are more. It's a huge list. It's a lot of rules we should follow. So let me look for them, and I'm going to send you some extra material, okay? Taking these ideas, we have bioethical issues. That issues is about euthanasia, for example, human fertility. Of course, it's not an easy fact to talk about these topics. Euthanasia, should the medical profession help the terminally ill to end their lives when they choose? Is that okay to finish with their life? It's a personal opinion, not a ruled one, because we are not God or anyone who sent us in life for choosing who's living or who's not. But sometimes we have to consider in two ways. If the patient is suffering, which one has more stability, suffering or treatment? The treatment is helping, no, so he's suffering. So is the patient, for avoiding the suffer situation, wants to die? Why not? It's so confusing. So we have to consider our point of view, the medical point of view, of course, and the legal in our country point of view. It's not an easy fact to answer. About the human fertility, we have to consider that situations as a general idea. What are the rights of a surrogate mother, one who carries a child for a woman who is unable to do so over the child? Is that okay to use the uterus of another woman to have my children? Is that okay? Is that an ethic? How can we measure how ethic is that possibility? Or maybe embryos can be frozen and implanted in the moment at a later date, but should this require the consent or permission of both parents if the marriage has broken down? Well, the matter if the marriage has broken down, there is an embryo that has the opportunity of living. A few days ago in internet, I was watching and having fun. I checked the news that frozen embryo was implanted into the uterus mother, a single mother, and it has 20 years of being frozen, and it's alive, and the pregnancy is going ahead without troubles. So it's possible to do. So why not? So I was telling you, it's difficult to give an answer at this moment. In vitro fertilization has made it possible for infertile women to have children. But should this include women look past the normal age of childbearing? Of course, we know that we have an age where, like like a train, and the train passes away and we lose the train. Okay, that's all. Is that okay if I, as a woman, have 50? Is that okay with my 50s to get pregnant and have a child? Hard to answer, right? Maybe on transplant surgery, who should give the consent for removal of body parts for transplant surgery? The patient that is in dead brain, or the relatives or someone else? In many countries, there is like a new situation. They have a tattoo in the chest that is taken as I'm a organ donor, take as you need, for example. But that tattoo is valid for considering the legal purposes of the transplant surgery? Of course not, because we need something that could be with more I don't know, with more supporting data about it. Maybe a credential card or a phone number or a contact to tell us that yes, he's agree, or maybe the possibility to get in contact to someone who got that information. With the genetic engineering, the dolly ship, do you remember the dolly ship? That was a genetic engineering huge ethical problem, bioethical issue that at this moment is still in discussion. Is that possible? Is that able that parents select the genetic makeup of their children? Of course, what we will say, or maybe get cloned in our kids. What we were supposed to think about it. That's the idea of the bioethical issues that we must consider, and sometimes we must fight with us and check in our common practice. And when it gets, you run crazy and said, what's going on? Why me? I tell you by experience. So it's not easy. And we have the assisted dying, the euthanasia, of course. We have a not clear picture. I'm sorry, I'm trying to correct it. I couldn't. But at this moment, it can be read, okay? With assisted dying, we have to consider the age, the situation. In this example, we have a 53-year-old woman with an incurable muscular dystrophy that flew to Switzerland to end her life. In Switzerland, it's a legal procedure. That's why many people go to their country, and then that's all. They finish with all the situation. Assisted dying is legal in Switzerland, but illegal in the UK and in lots of places of countries too. Of course, we have opponents of euthanasia, of mercy killing, argue that legalization would lead to abuse and call for doctors who participate to be stuck of what Britain needs. They claim is better palliative care and more hospices for the terminally ill to allow such as patients to die with dignity. But sometimes when we are opponents to this kind of situation, the assisted dying, how many of them treated that kind of people with incurable and complete terrible pain without a good evaluation? There's no possibility of understanding if you don't live in that way. This follows a recent US case where the husband of a woman had been in percentage vegetative state for 16 years, was successfully having artificial feeding withdrawn and despite opposition from his wife's parents. So if you have the possibility of paying, solving all the costs about it, and you are sure that your relative, your son, I don't know, anybody of your relatives is without pain, you can continue, in my opinion. But if even all the combination of drugs trying to control the pain are not enough, the pain is getting worse, why not consider the system dying if there is no possibility to get a solution? That's the theoretical situations we have to practice, we have to consider. And of course, it takes lots of time to get an answer. About the vocabulary is for yours, please read it and practice it. I'll try to correct it before sending you to the group. And don't forget, keep educating yourself all the time, reading and reading and reading. And if you check the medical history, you're going to find lots of examples about the 4 pillars of medical ethics for understanding these situations. And if you get in mind some cases, I don't know, difficult cases maybe during your practice or during the medical school, and consider these situations, you're going to see that at the moment you were practicing, you didn't have the answer about what you were doing, about what you could, how you could work about it, how you could give an answer. Okay. I had a patient in my 5th year in the medical school that she was with cancer, a terminal cancer. I mean, cervix. I'm not sure. I don't remember which exactly was. But she was 38, 39, no, or 40, no more than that age. She was dying in the hospital because in Cuba, all the patients, all the ones we know that need the hospital go, and there's no possibility of avoiding medical recommendations. You have to stay there and continue. If you need a surgery, you receive the surgery without saying anything. You cannot reject any kind of treatment. Supporting the idea that everything is free and the government is giving you by free, you have to make everything doctor said. Okay, that's communism. You don't have way of thinking. In that way, that patient was dying, and she said, "I'm dying. I know I'm going to die this weekend. Today is Thursday. I know I'm going to I'm not going to stay here until Sunday. So let me see my children. I have 4 children. What would you do? You let kids to get into the hospital and see their mother dying, or help your patient to go to the door, say goodbye to her children? What would you do? Or help your patient to escape, I don't know, to get away from the hospital for dying in a very painful situation at home? Because if you are not in the hospital in Cuba, with many specific situations, you don't receive the treatment at home. I tell you by experience. So what would you do? It's not an easy fact to answer. So let's consider this. Let's think about it. Let's practice about it and read more. Yeah, it's important. Any question maybe about this? I know it's a large
it's all clear.
presentation. I think it's clear, easy to understand, and
Yeah.
we have some expressions to practice and to do. If everything is clear, that's all for tonight. Okay. Tomorrow we have the workshop, and well, I'm still preparing the material for tomorrow, but I don't think we could check homework because there's a lot of topics that, well, that was a large homework, and 15 minutes is not enough for checking all the situations. So I'm going to send you the key as soon as I finish it, and you are going to compare the questions. And if you have questions to do, we can talk about it in an extra time. But for tomorrow, we have another kind of activity, okay? The activity is going to come from this presentation. So read it, practice it, and that's all. I think that's okay, okay?
Okay, thank you.
Okay, so see you tomorrow, everybody. And please fill the pool before going. It's for assistance, you know. Can you watch it?
Yes.
Thank you so much. The ones who are feeling it can go home at this moment. That's okay.
Thank you, Miss.
Thank you so much. Thank you for coming, for staying here.
Thank you. Goodbye.
Have a nice night. So see you tomorrow.
Goodbye. Have a good night.
Bye. Bye, Ari. Bye, everybody. Okay. Well, that's all. And I think that Agar is not here. Let me send her a message and let me help her. Oh, oops. Okay. Try to send. Try to end. Yes, I got. Oh, perfect. Okay, 9, 10, 11. Okay, so with this, yeah, with the sentence, we are finishing. Agar couldn't talk in the session, couldn't read because she's working at this moment. She's a physiotherapist at this moment. She has 2 careers. She's so smart. So that's perfect. And well, there's no problem for me.